Good morning, everyone. We're going to begin in a minute or two, but in the meantime, please introduce yourself in the chat. Tell us your name, the organization you're from, and what areas that you serve. All right, good morning, everyone. I think we can get started. So, welcome to Community Cares and Project Echo, the Survivorship series. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And I have a few announcements before we begin. So this is just a quick disclaimer that the information contained in this presentation is not substitute for medical consultation, and a physician should always be consulted for any health problem or medical condition. This is today's agenda. So we're going to do a Project Echo series overview, introductions, the actual presentation, a case study, and then we'll do questions and answers at the end. Throughout the presentation, if you have questions, please put them in the chat and we'll go over it. We saved like the last 10 minutes to go over the questions. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can visit echo.unm.edu. So now we'll do introductions. Our didactic speaker today is Dr. Bonnie Quinn. She is an assistant professor and epidemiologist at Rutgers Cancer Institute. Her research investigates how multi-level factors, including metabolics, lifestyle, and social drivers of health, influence cancer risk and outcomes, with a focus on breast cancer and ovarian cancer among racial and ethnic minority populations. She also serves as chair of the ASPO Cancer Health Disparities Special Interest Group. Our case study speaker is Dr. Nurzeen Omar. Dr. Nurzeen Omar is a cancer epidemiologist at Rutgers Cancer Institute in the section of Cancer Epidemiology and Health Outcomes. The overarching aim of her research is to translate epidemiologic findings into clinical care through more accurate risk assessment and to optimize risk-reducing strategies for outcomes after a cancer diagnosis. Specifically, she's interested in understanding the role of genetics, the environment, lifestyle factors, and their interplay on breast cancer etiology and prognosis. Dr. Xenomar is currently funded by the National Cancer Institute to examine the role of germline genetic variation in breast cancer prognosis. Thank you both for joining us today, and I'm going to pass my screen share over to Dr. Quinn.
Wonderful. And let me start sharing my screen. Okay, and let's see. Okay, could everyone see my slides? Wonderful. Good morning, everyone. I am Bonnie Quinn, assistant professor at Rutgers Cancer Institute. And I'm so delighted today to present together with my collaborator, Dr. Nurzeen Omar, regarding lifestyle and breast cancer survivorship. So breast cancer is the most common cancer in the United States. Considering both sexes together, breast cancer represents 16% of new cancer cases, and it accounts for 7% of cancer deaths. Among females in the US, excluding non-melanoma skin cancer, breast cancer represents nearly 1/3 of new cancer cases and 14% of cancer-related deaths, and is the second leading cause of cancer deaths after lung cancer. The burden of breast cancer does not affect all racial and ethnic groups equally. African American and the Black women have the highest breast cancer death rate among all racial and ethnic groups. The lower 5-year breast cancer survival rates among Black women are observed mainly for regional and distant stages. Part of the reason is that Black women are more likely to develop the aggressive triple-negative breast cancer, with the incidence nearly twice as high as that of other races and ethnic groups. However, the aggressive subtype and advanced stages at diagnosis do not fully explain the higher breast cancer death rate among Black women. This certainly highlights the need to identify strategies to improve breast cancer outcomes among this population. One question is, what modifiable lifestyle factors matter to breast cancer survivorship? The current lifestyle guidelines from the World Cancer Research Fund and the American Institute of Cancer Research recommend that after a cancer diagnosis, follow the cancer prevention recommendations if possible. And that include be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruit and beans, limit consumption of fast foods and other processed foods high in fat, starches, or sugars, limit consumption of red and processed meat, and limit consumption of sugar-sweetened drink, and limit alcohol consumption. And these recommendations for cancer survivorship are also consistent with the guidelines from the American Cancer Society. For lifestyle and breast cancer, we have more studies for breast cancer risk and less for cancer survival. Based on the literature review and meta-analysis from WCRF-AICR, the Global Cancer Update Program, we have strong evidence that higher BMI, waist circumference, and waist-to-hip ratio increase the risk of breast cancer deaths. There's some evidence supporting soy intake, dietary fiber intake, healthy eating patterns, and physical activity may reduce the risk of breast cancer deaths, but more studies are needed. Furthermore, cancer survivors face unique challenges. For breast cancer survivors, they may experience adiposity gain, higher risk of cardiovascular disease, sleep disturbance, cancer-related fatigue, cancer-related cognitive impairment, etc., which affect the quality of life after cancer diagnosis and treatment. In our 2021 review, we also highlighted a critical gap in nutrition and physical activity research among racial and ethnic minority cancer populations. So, how to put those lifestyle-related recommendations into actions? The American Institute for Cancer Research has this very nice summary, and I'm including it here. For example, how to be physically active. Start smart. Take a 15 minutes walk in the morning and in the evening to get 30 minutes of activity each day. And how to limit consumption of red and processed meat. Swap red meat for chicken, fish, or turkey. Use hummus or bean dip on a sandwich instead of processed meat. And how to limit consumption of sugar-sweetened drinks. Drink mostly water. Make a pitcher of fruit-infused water to add extra flavor. To address the current evidence gap and inform future recommendations, our team conducted studies to examine 2 research questions with a particular focus among Black breast cancer survivors. To what extent does adherence to cancer-related nutrition and physical activity recommendations reduce breast cancer mortality? And to what extent does adherence to cancer-related nutrition and physical activity recommendations improve patient-reported outcomes, including sleep disturbance, fatigue, and quality of life? And this investigation was supported by the American Cancer Society. My research on breast cancer survivorship among Black women is largely based on the Women's Health follow-up study, and I'd like to describe the cohort design. The Women's Health follow-up study is a population-based longitudinal study of Black breast cancer survivors in New Jersey. It's designed to understand obesity and related comorbidities, physiological pathways, and breast cancer outcomes. Doctors Elisa Bandera from Rutgers Cancer Institute, Chi-Chen Hong from Roswell Park Comprehensive Cancer Center, and Kita Damasi, now at SUNY Downstate, are the cohort MPIs, and I have been fortunate to be part of this investigator team since 2015. The study consists of several components. We conducted home interviews, which included questionnaires, biospecimen collection, anthropometric and blood pressure measurements. We also conducted phone surveys. The study also includes medical and pharmacy records review related to cancer diagnosis and treatment and management of obesity-related comorbidities. Before the follow-up study on breast cancer survivorship, the earlier study, which used the same recruitment strategy, was a case control design to investigate breast cancer etiology. And cases recruited in New Jersey during that phase, together with participants recruited for the follow-up study, are linked to the New Jersey State Cancer Registry annually for mortality outcome updates. Let's take a look at participants' characteristics in the Women's Health follow-up study. Among 1,710 participants with complete lifestyle data, the mean age was 54. Close to 30% of our participants had a household income less than 25,000 per year, and 57% had private health insurance, while 11% were uninsured. The majority of our cases were diagnosed at stage 1 and stage 2, and 18% had triple-negative breast cancer. And if not counting unknown subtype, this means 21%, which aligns with the literature regarding the high prevalence of triple-negative breast cancer among Black women. We have estimated the extent to which our participants met the nutrition and physical activity guidelines before breast cancer diagnosis. The first recommendation is maintaining a healthy weight, and the ideal score is for BMI within the normal range and the waist circumference below 80 centimeters for women. And for the weight component, only 6% of our participants fully met the recommendation. The second recommendation is to be physically active of at least 150 minutes per week of moderate to vigorous physical activity. Although 37% met the recommendation before diagnosis, 55% had a score of 0, meaning they engaged in less than 75 minutes per week. The third recommendation is to eat a diet rich in whole grains, vegetables, fruits, and beans. And only 8% of participants before diagnosis fully met the recommendation, which is fruit and vegetable intake of at least 5 servings per day and fiber intake of at least 30 grams per day. Another recommendation is to limit consumption of ultra-processed foods, which are high in fat, starches, or sugars. The score was assigned based on tertiles of consumption of our study population as recommended. The ultra-processed food is the only variable for which the score is based on the distribution of each specific data set to partly account for variations in ultra-processed foods across different populations' food systems. Next is to limit red and processed meat intake, which is red meat intake less than 18 ounces per week and processed meat intake less than 3/4 ounces per week. And only 20% of our participants achieved this recommendation. For sugar-sweetened drinks, the recommendation is 0, and only 8% achieved this. More than half participants consumed 8.5 ounces of sugar-sweetened beverages per day. The final component is alcohol, and 60% met the recommendation of no alcohol consumption. So among these 7 lifestyle components, we found that more than 50% of participants were far from meeting the pre-diagnosis lifestyle recommendations for weight, physical activity, sugar-sweetened drinks, or red and processed meat. This suggests that intervention strategies should focus on improving these lifestyle factors. The total lifestyle pattern score is 0. The range is from 0 to 7, and higher scores indicating better adherence to cancer-related lifestyle guidelines. And among participants in the Women's Health follow-up study, the average score was only 2.9. And in the multivariate models, after adjusting for age, education, household income, health insurance, marital status, and smoking status, We found that women with the highest lifestyle scores, 5 to 7, had a 39% lower mortality compared to those with the lowest scores, 0 to 2. We also found that women with the highest lifestyle scores, 5 to 7, also had 31% lower breast cancer specific mortality compared to those with the lowest lifestyle pattern scores, although it was not statistically significant. I also wanted to note that the associations we observed here were independent of individual socioeconomic status. However, we know from our previous studies and others' work that strategies to improve lifestyle pattern may also need to target social determinants of health factors, such as affordability and access to healthy foods. We also assessed the sleep quality after diagnosis using the validated Pittsburgh Sleep Quality Index and also quality of life measured using the validated questionnaire FACT-B and the fatigue using FACIT-F, and all measured about 2 years post-diagnosis. We found that nearly 60% of Black women reported clinically significant sleep disturbance 2 years post-diagnosis, and 22% experienced severe fatigue. And for health-related quality of life, there's no established clinical cutoff points. So here we show the food distribution, and you can see there's a wide range of health-related quality of life scores among breast cancer survivors, indicating substantial variations in survivors' well-being. We found that higher adherence to lifestyle recommendations was associated with a lower risk of sleep disturbance. We also found that higher adherence to lifestyle guidelines was associated with lower risk of poor quality of life and non-significantly associated with a lower risk of fatigue. So while I'm interested in understanding how individual level lifestyle factor affect cancer survivorship, I attended a talk about 10 years ago by Dr. David Williams. He asked the question, what do we accomplish if we treat illness and send people back to the same conditions that created the illness in the first place? So really inspired by his question and emerging research of social determinants of health at that time, my team has also included area-level social and built environment factors into the research agenda. The figure here is from the review paper by Dr. Gomez and her team. It's a great review on how social and built environment may influence the cancer continuum. The social environment refers to the social aspects of the community and the environments, and the potential pathways that social environment may influence cancer include stress, social network, health behaviors influenced by social norms. Built environment refers to the physical attributes that affect walkability, food environment, medical services, etc. And the built environment may influence the cancer continuum by affecting health behaviors such as physical activity, diet, social support, etc. So let me share a study where we evaluated neighborhood factors as well as other levels of factors with cancer survivorship outcome. Weight management is the target here because it's a really crucial issue in breast cancer survivorship, because breast cancer survivors are likely to experience unfavorable changes in body composition. And due to its clinical significance, weight management has been included in the ACS ASCO breast cancer survivorship guideline. So we conducted a study to identify multi-level factors for adiposity change among Black breast cancer survivors. And the multi-level factors refer to individual social demographic and lifestyle factors, clinical factors, and neighborhood social and built environment factors. And the adiposity change outcomes include gain in body weight and fat mass. We have also examined factors associated with intentional and unintentional weight loss, but due to time constraints of today, I will not present those findings. However, the paper has been published in the Journal of Clinical Nutrition, and I have the citation here. So we had 785 participants for this study, and during home interviews, trained interviewers measured participants' weight, height, and body composition. Between 10 months to 24 months after diagnosis, we found that 52% of breast cancer survivors maintained their weight, 28% experienced weight gain of at least 3%, and on average 12.6 pounds. Also, 9% of participants had intentional weight loss, and 11% had unintentional weight loss, which could be related to cancer cachexia. When looking at fat mass gain of at least 3%, 47% of participants experienced at least 3% fat mass gain. And this is really concerning because 86% of our participants were already overweight or obese at baseline. I listed here the individual level and neighborhood level risk factors under investigation for weight change in this study, including social demographic factors, menopausal status, lifestyle factors, comorbidities, and clinical factors. And at the neighborhood level, we included neighborhood socioeconomic status, racial and ethnic density, food environment, physical activity facilities, and walkability of the neighborhoods. So at the individual level, we found that older age, higher household income, and postmenopausal status were associated with lower risk of weight gain. In other words, younger age, premenopausal status, and lower income were associated with higher risk of weight gain. We also found that participants with a higher BMI at baseline were less likely to gain additional weight. Among lifestyle factors, former smoker and decreased physical activity since diagnosis were associated with higher risk of weight gain. For clinical factors, we found that higher tumor stages and having chemotherapy were associated with higher risk of weight gain between 10 months to 24 months after breast cancer diagnosis, and consistent findings were observed for fat mass gain. Now, let's look at the neighborhood level risk factors for weight gain. The strongest association was observed with fast food restaurants. So participants residing in neighborhoods with the highest density of fast food restaurants had an 82% higher risk of weight gain compared to those in areas with the lowest density. And the greater density of fast food restaurants were consistently associated with a higher risk of gaining fat mass. We also found that women living in areas with greater walkability were less likely to gain weight. But it's worth noting that physical activity facilities were not associated with weight gain, since these facilities often require a membership, transportation, or extra travel time. So it's really not clear whether they're truly accessible for our participants or not. So in summary, we found that there are some common challenges in breast cancer survivorship: sleep disturbance, cancer-related fatigue, and adiposity gain. We showed that diet and lifestyle may play an important role in quality of life and survival. Specifically, we found that high adherence to cancer-related lifestyle guidelines was associated with lower mortality, lower risk of sleep disturbance, and higher quality of life after breast cancer diagnosis. And beyond individual socioeconomic status, lifestyle, and clinical factors, our findings also suggest that several neighborhood environment factors collectively impact weight changes after breast cancer diagnosis. However, some cancer patients, they face environmental barriers which should be considered in their survivorship care. So the work I just presented is truly the result of a team effort. And thanks to Dr. Elisa Bandera and Dr. Noor Zinomar at Rutgers Cancer Institute and the Women's Health Follow-up Study Scientific and Community Advisory Board, as well as my other collaborators. And special thanks to our wonderful study participants who are really brave women. Thanks so much, everyone, for listening. And I will now pass the stage to Dr. Zinomar.
Thank you, Dr. Quinn, for an excellent presentation. Let me share my screen. Let's see, screen one. Okay, and then So you guys can see my screen? I think so, right? Okay, so
Yes.
hi everyone. Yeah, perfect. So hi everyone. I'm going to kind of pick up where Dr. Quinn left off, and today I'm going to be talking about lifestyle factors and breast cancer risk and survivorship with a focus on smoking and alcohol. And so I usually start all of my talks with a lot of the background of breast cancer epidemiology and the risk factors, but Dr. Quinn has really done a great job going over all of that. So I'm going to just jump right into it. One may ask, why even focus on smoking and alcohol in breast cancer survivorship? Well, to start, as you all know, there are over 4 million breast cancer survivors in the United States. And so we really need to understand factors that influence their life and outcomes after a diagnosis. And these cancer survivors have competing causes of mortality or of death, including cardiovascular disease and second primary cancers. And lifestyle factors, including smoking and alcohol, can impact breast cancer recurrence or the breast cancer coming back, treatment toxicity, overall survival, and very importantly, their quality of life. And so I wanted to first, before I dive into the two studies that I'm going to highlight today, I wanted to go over some of the biological plausibility of why we look at smoking and alcohol in both risk and prognosis. So with alcohol, we know that it's associated with an increasing circulating level of estrogen. We know that the metabolites, or the alcohol metabolites, produce reactive oxygen species, which have been associated with DNA damage, which is then associated with increased risk of cancer. We know that alcohol consumption can be associated with folate deficiency, which actually increases the tissue susceptibility, impacts the tumor microenvironment to carcinogenesis. And we know that it increases the greater metastatic potential of the breast cancer cells themselves. In terms of smoking, smoking is an environmental toxin, and so it creates these bulky DNA adducts. Um, it is associated with oxidative stress, chronic inflammation, immune suppression, and cardiotoxicity with some of the breast cancer treatments. And so you can see that it's really very important exposures to study both for risk and survivorship. And so what has, I'm going to move this right here. Okay, so sorry, I don't see myself. And so, what has the epidemiologic studies shown us with respect to alcohol? I think that most folks, when I talk to them, are very well aware that smoking is associated with both cancer risk, people think of lung cancer, and mortality. But alcohol is also an established risk factor for breast cancer, and it's associated with about a 7 to 10% increase and breast cancer risk for each standard alcoholic drink consumed daily. On the left, you see a summary from the Continuous Update Project, which many of you are probably familiar with. And you can see that alcohol is associated with increased risk for several cancer sites, including breast cancer. For cancer prevention, the AICR, or the American Institute for Cancer Research, which Dr. Quinn went over with her recommendation, recommends actually that there's no safe level of drinking alcohol. But if we must drink, then we really should be limiting consumption to no more than one drink a day for women if they choose to consume alcohol. And here you can see what a standard drink is. And so really it's a can of beer, um, uh, a glass, or really 5 ounces of wine, or 1.5 ounce of liquor. And you know, the journal or the Journal of Clinical Oncology published a statement for the American Society of Clinical Oncology a decade ago now on alcohol and cancer, recognizing its important role in both cancer risk and prognosis. And so the first study I'll present today is going over um, really focused on risk. And so it's going to be understanding whether these two risk factors, both smoking and alcohol, are modified by underlying familial risk of breast cancer. And understanding this is really an important first step in developing appropriate clinical recommendations for women across the risk spectrum. And so I was really lucky that I was able to conduct the study in Prophecy, which is the prospective family-based cohort that is enriched for individuals with a family history of breast cancer. And the PI for this study is Dr. Mary Beth Terry at Columbia University that I worked closely with while I was there. And it includes over 31,000 women for over 11,000 families across 7 different study sites. And 6 of the sites are from the Breast Cancer Family Registry and the Kathleen Cunningham Foundation Consortium for Breast Cancer in Australia and New Zealand. And it's a very unique cohort to be able to answer this question in that it's one of the only 2 large prospective breast cancer cohorts that is specifically enriched for high-risk women. And this includes both women with and without a breast cancer diagnosis. And for this study, I focused on who we refer to as the unaffected women. So these are women without a diagnosis yet. Um, and we've collected a lot of different important factors, epidemiologic risk factors, and then as well as pathology records, which went over all of the clinical characteristics. And we also collected detailed information on smoking and alcohol. These are based on self-reported information from baseline questionnaires that included the status of smoking and drinking, how long they smoke and drink, the age at initiation for smokers, the average number of cigarettes, and the average number of each type of alcoholic drink consumed per week. Um, and so for this study, or for this analysis, I included over 17,000 women from nearly 7,000 families who had complete information on both alcohol and smoking. And we were able to follow them for an average of 10.4 years. And over that time period, we observed over 1,000 incident breast cancer diagnoses. And what I mean by incident is these are new breast cancer diagnoses from the 17,000 women. And just here are some baseline characteristics of my study sample in terms of drinking. We saw that over 49% of women in our study reported being regular drinkers, and they consumed an average of 7.7 alcoholic drinks per week. So that's around a little over a drink a day. In terms of smoking, 15% reported being current smokers. And smokers were actually more likely to be regular drinkers and consume more alcoholic drinks per week than people that never reported smoking. And so I'll jump right into the main results. Um, we didn't see, so remember, this is a high-risk cohort, so we didn't see statistically significant associations between alcohol consumption and overall breast cancer. Um, and then when we broke it up by estrogen receptors subtypes, however, when we examined this by underlying familial risk, we did observe um, that uh, a higher alcohol intake compared with no alcohol or non-regular drinkers was associated with an increased risk of ER-positive breast cancer. And this is consistent with what we see in average risk populations, so women that are at average risk for breast cancer. So I was very motivated by this. And so this figure shows hazard ratios for alcohol consumption by the percentiles of underlying familial risk profile. You can see here that it's associated, these are the women at the lower end of the risk profile. So these are average risk women, and it's associated with about a 47% increased risk. Um, And then in terms of cigarette smoking, we found no statistically significant association between smoking status and overall breast cancer risk or by estrogen receptor status. And then there was no interaction when we looked by underlying familial risk. And this is illustrated in the figure here with the top panel showing the association of being a current smoker compared to never smoker for overall breast cancer, and then by percentiles of the underlying familial risk profiles. And then when we looked at smoking intensity, age at smoking initiation, and smoking duration and pack years, we also saw no association. But when we examined smoking status within the strata or within levels of alcohol consumption, we did find that women who were regular drinkers and were at the higher end of the risk spectrum were at this increased risk. So if you look at the top panel, there's a 30% increased risk for overall breast cancer for women at the 95th percentile of this familial risk profile. So these are the highest risk women who also reported being current smokers and were also regular drinkers. Um, and so how are so that kind of concludes my first study, but then this begs the question is how are alcohol and smoking associated with outcomes after a breast cancer diagnosis? We know Let's see. Okay, so we know that having a healthy lifestyle includes not smoking and limited alcohol consumption. And so today we're we focused on risk, but the evidence for an association with breast cancer prognosis has been a lot less consistent than for risk. And then smoking, it's a little clearer for prognosis in that smoking at the time of a breast cancer diagnosis has been consistently associated with increased risk of mortality, both breast cancer specific and all cause, although this is really unclear how it varies by race and ethnicity. And there's really limited data on how lifestyle factors are associated with breast cancer prognosis in Black women, as the majority of evidence is based on studies conducted in white women. And so, why focus on Black breast cancer survivors anyway? Well, to begin with, Black breast cancer survivors have a 38% higher mortality compared to their non-Hispanic white countertops. Um, uh, Counterparts. Um, they are also more frequently diagnosed with more aggressive tumor subtypes. They have a higher burden of comorbidities that these exposures would just make worse. They are underrepresented in survivorship studies, and they have different exposure patterns, which we're going to see in a minute. And so this kind of motivated the study that I'm the second study that I'm going to highlight today, which is based in the Women's Circle of Health follow-up study. And we examined the association of pre-diagnosis cigarette smoking, alcohol consumption with survival in a large cohort of breast cancer survivors that Dr. Quinn has done a great job going over. So I won't go over in too much detail, the study design, but I will say that it includes over 1,900 Black breast cancer survivors that we identified in 10 counties in New Jersey through the New Jersey State Cancer Registry. And so, similar to the study in prophecy, we collected data during in-person interviews at home visits, and alcohol consumption was again collected the year before or asked about for the year before diagnosis, and similar for cigarette smoking. And here we also estimated pack years. And so, as shown in the figure on the left in blue, we found that compared to never smokers, oh, okay, so maybe um, we'll talk about that first. So, current smokers had a 2% increased risk of mortality. And these models were adjusted for age, estrogen receptor status, tumor stage, household income, and waist to hip ratio. We also looked at among the current smokers, the pack years. So this pack years also incorporates intensity and duration. And we found that the woman that smoked the most and with the longest had now an 84% increased risk of overall mortality. compared to never smokers. And then when we looked at um, uh, breast cancer specific mortality and all-cause mortality by drinking status, similar to what I did in Prophecy, we found that women that currently smoked and regularly drank had the worst survival. So compared with non-regular drinkers who never smoked, current smokers who regularly drank had a 69% increased risk of all-cause mortality, whereas the association for current smokers that were not regular drinkers was a lot less substantial. Um, that's shown here. And so, just in summary for study 2, we know that current smoking at the time of diagnosis was associated with increased risk of all-cause mortality, particularly among women with greater pack years of smoking and who were regular drinkers. We observed similar association for breast cancer-specific mortality, and with a 67% increased risk of breast cancer-specific mortality for current smokers who regularly drank, but no association for current smokers who are not regular drinkers. Um, we didn't observe an association for alcohol consumption, but I want to note that alcohol consumption was actually quite low for women in this cohort, which is consistent with what we see in the general population, with Black women consuming on average less alcohol than their non-Hispanic white countertops. Oh, okay, yeah. I just mentioned that. And so really understanding how these modifiable factors are associated with breast cancer prognosis is important when we think about clinical recommendations and management of women following a breast cancer diagnosis. And all of this work wouldn't have been possible without the wonderful team at both Rutgers and Columbia University, including Dr. Quinn, who's here on the call, Dr. Alyssa Bandera, who's the PI of the Women's Circle of Health Follow-Up Study, and Dr. Mary Beth Terry, who's the PI of the Prophecy Study. So thank you so much, and here's my email. Feel free to reach out to me, and I'll stop sharing.
Thank you both so much. That was amazing. I'm gonna go back to sharing my screen. Okay. Share from. Okay. I know we have a question in the chat. Evelyn, do you mind reading the question? Because I can't see it anymore. Now that I heard
Sure.
it.
The question is, could you elaborate on the reason to avoid intake of supplements in cancer prevention?
Yeah, I can explain more. So I think that's a great question. So the current recommendation is not to use dietary supplements, but based on diet for cancer prevention. So the reason is really because there is consistent evidence from randomized control trial that they consistently didn't show the benefits of taking dietary supplements for cancer prevention. However, I think I should mention is that the only exception is for calcium supplements. There's probable evidence. So the evidence level, there are some rankings and now it's listed as probable. So not the strongest, which means more studies are still needed, but there's probable evidence showing that dietary calcium supplements may decrease the risk of colorectal cancer. However, I think I should also mention is that foods high in calcium, such as dairy products, were also found to decrease the risk of colorectal cancer. But certainly more studies are needed. And also there's strong evidence from randomized control trial showing that high dose beta carotene supplements may actually increase the risk of lung cancer in some people, especially among those smokers and those who were former smokers. So because of all the generally consistent evidence not finding the benefits of dietary supplements and even very strong finding from for high dose beta carotene that may increase the risk. So the current evidence, the current recommendations support that using whole diet, if possible, for cancer prevention rather than relying on dietary supplements. I hope I answered your question, but I think this is a great question. Of
I
course.
don't see any other questions in the chat. But Dr. Quinn, were you going to say something else? I'm sorry, did I cut you off?
Oh, no, I just want to say thank you, Janet, for this question.
I have a question. Um, there's been an association between vitamin D deficiency and breast cancer. What do you think about that?
Yeah, that's also a great question. However, let me double check the current evidence that I don't really think that vitamin D supplements and breast cancer risk, they are considered to have sufficient evidence to support using vitamin D for breast cancer prevention. In fact, I believe the VITAL study, which is a randomized clinical trial, double-blinded, that was published in New England Journal of Medicine in 2021, actually showed that dietary. I know there's some comments about the study design and the limitations, etc. But based on this, so far the largest and the longest follow-up of clinical trial on dietary vitamin D, I don't remember that there is strong evidence for breast cancer prevention. I vaguely remember, I need to double check the paper, but I vaguely remember they showed some suggestive evidence for high-risk population in certain cancer type, but overall, the findings were not supporting vitamin D supplementation for cancer prevention, including breast cancer.
Yeah, the vitamin D data seems to have fallen apart in almost everything. But
Yeah.
there was a lot of enthusiasm for it, 10 years ago.
Yes.
But that's not to replace if someone has a deficiency and their doctor recommends a supplement,
Yes.
of course,
Yeah,
that's a
well,
completely different story.
absolutely. But it's
Yeah.
funny because the American Society of Endocrinology has recommended against checking vitamin D levels on a regular basis. So, that recommendation was just within the last year
So
that
does that mean I can save money on my not getting my supplement? Because I keep getting yelled at that it's too low.
Yeah, most of us are low. I think in this part of the country, in the winter we're low, in the summer we're better, but it probably evens out. And for bone health, it probably makes a difference. But for
Yeah.
cancer, that data seems to have fallen apart for the most part.
Wow.
Exactly.
And
Yeah,
for
I want to
prostate cancer
mention,
also, right? I mean, they were looking at it for prostate cancer, for colon cancer. That data seems to have fallen apart.
So we have another question. I think this is another great question that we have. I wonder if you asked the participants if they are primary caregivers and how that played into their risk. We know women usually bear the brunt of at-home responsibilities, and lots of these lifestyle factors take time, and we tend to put ourselves last.
that's a fabulous question. Uh, so although we didn't really ask our participants if they were primary caregivers, but we actually noted from our study and together with other studies, I'm very involved in ovarian cancer study, that we found that for among those, so we compared those who completed our lifestyle questionnaire, particularly the long food frequency questionnaire, versus those who did not complete the full interview. And we found that a lot of factors, they remain consistent between those two groups, the age, the clinical factors. However, the number of kids actually play a role in completing the study. So more kids, less likely to complete the study. So that suggests something about whether our participants, if they had time to participate in research. So let me see if I answered that question. Oh, and whether that also relate to their health outcomes. That we do not know because we actually couldn't really collect data from those really busy women.
And that right there gives you some data. Huh? So I have another question here. What about navigation support while they are survivors and additional resources they may have to help support their wellness? What difference does that make for their survivorship?
I wonder if Dr.
Yeah,
Zinomar, you want to cover that question?
I was going to say, I don't know that we have, so Dr. Quinn, feel free to jump in. I don't know that we have data on all of the navigation support during their survivorship period and additional resources, but certainly that is something that should be looked into, and you would think that it would make a difference. But do note that for the Women's Circle of Health, we did interview these women about a year after their diagnosis. So their active treatment and all of that is completed by then. And so maybe we can look into additional resources kind of later on into the survivorship period, but the navigation support would be a little closer. But you would think that it would make a difference. So we just don't have the data to really say whether it does or doesn't. Dr. Quinn,
Yeah,
anything else?
yeah, we don't have direct evidence on navigation support. However, we, together with Dr. Zinomar and the other team members, we have shown that for our participants who are Black breast cancer survivors, they're more likely to reside in neighborhoods compared to, the whole New Jersey. They're more likely to reside in the neighborhoods that are high in densities of fast food restaurants, low in densities of physical activity facilities. And we clearly show that they play a role in breast cancer survivorship in terms of weight management. So that is an indirect evidence that they encounter environmental barriers that would need additional support to overcome those barriers on their weight gain issues after breast cancer treatment.
Thank you for answering that question. And I raised that because when I was thinking about the study and wondering how much of that support could be factored into the solution around those particular issues. So when you're talking about the weight gain, and you're talking about the foods and the other issues in the smoking, where is the support that can help them address those issues, help them address, the nutrition aspects, and those things matter and those things are helpful. So the solutions to that, in addition to those items that you suggested, having that good foundational support from their community members, from their family members who are often going through it with them as they're going through their survivorship. So I just offer that as a recommendation.
No, thank you, Monica, so much for that comment. I do want to make one additional comment is that Dr. Quinn and Dr. Bandera and our team has been working with the Community Action Board, and we have been trying to have bidirectional communication with the community in terms of how do we best translate these findings to the community in the way that's the most effective for them. So we're hoping to do more work with that as more results come out from our studies.
And we have one last observation. I apologize, I missed that one initially. I appreciate the focus area here. I always wonder why and how breast cancer screening rates and treatments are similar across Black and white women. However, diagnosis of new cases and 5-year survival rates differ so much. I think we just touched upon that a little bit. Obviously aware of social determinants, but happy to hear conversation and research about the differences. Lots of great points being discussed here. Grateful I was able to join. Thank you. Thanks all. So I think some of that was answered just with the previous question as well. I don't see any other questions.
Wondering, Dr. Quinn, if you want to touch on that question. It's a very good question. It is something that the field is trying to figure out why Black women have lower survival rates. I can just and Dr. Quinn is an expert on this. I can touch briefly that part of it is the tumor subtypes, the age at which they're diagnosed, and it can't all be explained by access to care. And so that is something that the research community is working diligently to try to figure out, but also address. But I'll let Dr. Quinn.
Yeah, I agree with what Dr. Zinomar was just talk about. So the reasons we think that there are multiple reasons from biological reasons behind, including more aggressive subtype to social drivers of health. For example, the quality of care and also the differences that we already know from lifestyle factors, whether that we know that for racial and ethnic minority women, they are less likely to meet recommendations than white women. So we think the reasons that there are multiple, and even for the biological reason of triple negative breast cancer, researchers are really actively working on that to investigate the reason. Um, so stay tuned with us, and we hope that we can show more findings from our group and our field researchers.
I also want to point out, and something that we maybe don't think about as often is I was at a conference and someone had a poster about it was studying Black immigrant women in New York City and their acceptance of mammography. And one of the items that really stood out to me was that a lot of women were not treated well by the people who worked at the radiology place where they went for the scans. So they did not want to come back. So that's something that we have to be really aware of as well. And a lot of Black women have like the worst rates of providers listening to them. So I think we have to take that into consideration as well. That may be affecting rates. I always ask people when they say they can't figure out what's going on, I'm like, how does the team treat the patients? How does that first person they're dealing with, how are they treating that patient when they walk in the door? Are they going to want to come back? So that I think is another thing we really have to take into account.
Yeah, and we can't miss that part. And thank you, Evelyn, for mentioning that because that was right there on the tip of my tongue. We can't miss the part of historical atrocities in the medical field against Black women, and is not taken lightly because it still exists, right? So when we talk about all of those different factors, one of the things, and I get that this is a study, and I appreciate the research, but one of the things we have to take into account is it's not only on them, right? It is about access. It's about quality access. It's about how the medical professionals treat Black women. It's about how they hear their stories and their voices and understand their pain to give them and offer them the right kind of treatment. I could tell you, my mother, you had a mastectomy about a year and a half ago, and what made the difference for her is she had me, her daughter, staying on top of the providers, even though she's down in Georgia, still having those calls. My sister's there. She has the resources. We made sure she got connected. We made sure that they understood, what her pain was and how they're going to treat her. So that advocacy piece for women in the medical field so that they're treated respectfully and with dignity is so important. So thank you.
That actually reminds me that as part of our survivorship series, we're going to be doing a advocacy and stigma session. So if you want to know when that's happening, check the Mighty Networks. Everything is posted on there, and you can join through the Mighty Networks too. So thank you for bringing that up, and thank you all for sharing your experiences, your questions. This was a great session. I love when we can just unmute and talk. And thank you, Dr. Bonnie. Thank you, Dr. Zenomar, for helping us like with the questions, presenting for us. I really appreciate it. I have a few more slides to go through. And also, if you come up with questions later, everything will be posted on the Mighty Networks, and I'll be sending them the Mighty Networks link so they'll be able to answer your questions. Please make sure to do the evaluation form. We really look through that. If you have any suggestions on how we can improve, anything that you want to see done in the survivorship series, please let us know. Let's see what else I have. So in our state, we have NJ Seed. The phone number and the link will be posted in the chat, as well as the evaluation. And I can leave this up here too. And the Mighty Networks link will also be posted. So join us next month for a session on pelvic disorders in cancer survivors. It's a women's health focus session. So thank you all for attending. Thank you to our speakers.
Thank you, everyone.
Thank you for having us. Great discussion. Bye, everyone.
Thank you. Bye.
Thank you.
Bye.
Bye.
Bye.